Next on For Your Health, there's been a lot of talk about how healthcare reform will affect individuals, but what are the implications for hospitals? We'll explore that question. Stay with us.
This program was made possible by a grant from the UCF College of Health and Public Affairs, which promotes excellence in undergraduate and graduate education, research, and community service in health-related professions and public affairs.
Hello, everyone. Welcome to For Your Health. I'm Charna Wiese.
And I'm Aaron Lieberman from UCF's College of Health and Public Affairs, sitting in for Ed Highland. On today's show, we're discussing healthcare reform and its implications for hospitals.
We have two guests joining us today. Andy Gardner, Vice President of Community and Government Relations for Orlando Health, and Rich Morrison, Corporate Vice President of Government Affairs for Adventist Health Systems. But first, technological advances in medicine are usually very exciting to doctors. But there's one advance that's meeting with some resistance, and that is informatics. For doctors, it means giving up the clipboard, the prescription pad, and the dictaphone to go electronic. As Alicia Callanan-Mandigo reports, as an industry, electronic medical records is really in its infancy.
These UCS students are a bit unique in that they're studying the same discipline and yet see themselves differently. A few are tech heads, some are healthcare providers, and some see themselves as business leaders. All of them are studying informatics.
Informatics, or healthcare informatics, is basically the use and the study of data in healthcare. It's an emerging field in the fact that it is somewhat interdisciplinary, and we're pulling from computer sciences, we're pulling from healthcare, and we're pulling some from health administration, at least in the UCF Healthcare Informatics program.
This particular exercise is geared toward helping doctors understand the need for informatics. Think in terms of electronic medical files.
This can change the quality of care that we provide so drastically. We can change all of these prescription errors, all these medical errors. We can help the very prevalent act of physician hopping, and I'm going to go here and get a prescription, I'm going to go here and get a prescription, and all of that can really be alleviated through the use of health information technology.
UCF offers the state's only Masters in Healthcare Informatics, and the program is proving very attractive.
I came to UCF and I found HIM. It had a mix of kind of what I was looking to do, which was a mix between business and health, just applied on the business side instead of on the clinical side. I didn't know much about it, but I like technology, business, and health, so it seemed like a good fit.
One of the unique aspects of this program is that it's completely online, which means you don't have to worry about showing up for class. It's almost as futuristic as informatics itself. In fact, there's even a student in Hong Kong enrolled. Scott Bennett is a former Department of Defense engineer who became intrigued with informatics.
What I find fun is that it's kind of at the beginning stages. I've been through it on the intelligence side, how things went and how fast things progress once they get on a path, how much innovation comes about, how much disruptive technologies come out of it, and that part of it is just so much fun to watch and then implement along with other new systems and stuff that come along. That's what I look forward to doing.
Electronic records, a national health information exchange. These are still new ideas, which is why this student exercise is focused on helping doctors understand the need for informatics. It won't be an option. Informatics will be standard operating procedure for our healthcare system.
So the jobs are there in a variety of different places. One is the regional extension centers that are coming up around the country that got federal funding. A lot of software vendors, all of a sudden all of these people need your software, and you need people that know how to implement the systems and also have the ability to speak to the IT people as well as to speak to the clinical providers as well. And so informaticians are really poising themselves to be in a good position to do that.
In the short term, informatics means jobs for these students. In the long term, it means a safer, more efficient healthcare system for everyone. I'm Alicia Callanan-Mandigo for Your Health.
While the push for healthcare informatics precedes the Obama administration, healthcare reform may be contributing to the need for an expanded informatics workforce.
If you've brought up healthcare reform in a recent conversation, you might have been left feeling like you stepped in an anthill. It's a topic that can trigger some biting opinions.
Even so, it's something that needs to be discussed and understood by all of us. To help us with that today are two hospital administrators, Rich Morrison from Florida Hospital and Andy Gardner from Orlando Health. Thank you both for joining us today.
Thank you.
Let me toss out the first question to you, Andy. As you look at the future, the immediate and long-term future, healthcare reform looms on the horizon like a big bus. Where do you see it going?
Well, there are a few things that we know have already been implemented. It's really more the insurance side, the initial pre-existing conditions and some of the other things that took effect immediately. The one thing that I think everybody involved in healthcare, whether you're a provider or even an insurance company, wherever it may be, is the long-term implementation of the plan. The way it is going to be phased in through, I believe it's 2020. So a lot of us are spending a lot of time trying to figure out exactly what the rules are going to be, knowing that there's a lot of political activity in between that obviously will have an impact on whatever happens in the future.
And many elections between that time, so who knows what's going to happen and which way everybody's going to turn.
Well, let's look at the political side of it, Rich. You work in that every day. What from your standpoint is the take on the politics of healthcare reform?
Well, the politics, I think, are going to be very interesting because if you look at this last election, you obviously had control of the House swing to the Republicans, and they've talked about repealing healthcare reform. The reality is that's not going to happen because they don't have control over the Senate, and there's still a person sitting in the White House who has a veto. But I think you'll see some moderation taking place on some of the things that were passed. I mean, already you're seeing folks come in to get stays, if you will, exemptions from having to implement some things. And I think some of the more egregious things that you find in the bill or some things that were just not thought through are going to be dealt with politically. But then the great unknown is the latitude that the regulators have, which would be CMS and others who pass rules, that they can interpret the ambiguities of the law as they wish to, and there's very little that can be done about that except maybe a congressional override, congressional hearings. So the politics are going to be real fascinating over the next few years.
And I think also you need to add in there a presidential election in 2 years, which my guess is this legislation or this idea will probably be the hottest topic of the presidential election in 2012.
And we've seen so many changes with that. For example, when President Clinton tried to do healthcare reform, at that time the economy was better and people didn't seem to be as excited about it, and it didn't work, and it wasn't that big of a hot topic as it is now with the economy not doing as well.
It was very interesting. I was, old enough to have been involved in the whole Clinton approach. And what's fascinating, you talk about politics, with the Clinton approach, it was a managed care approach. It was heavily managed care and was fought by the Republicans because it was very constraining. Now you have the approach that was, not managed care driven necessarily, but the Republicans have taken much more of a managed care approach over the last several years. So you can see how the politics and the attitudes change over time. So who knows what's going to happen in 2012 and beyond.
Well, as we look at healthcare in general, Andy, we think of transactions in the United States in our capitalist society as a two-party transaction, but in healthcare it's very different. Could you talk a little bit about the differentiation?
Well, obviously in healthcare, it's not just the patient and the doctor. You have the insurance company, you have potentially Medicare, Medicaid, the government involved. If it's the primary physician, and then you're referred to the specialist, and it could be 30 or 40 different people that potentially are involved depending on what your situation is. So it's a very complex area and a very interesting time to be a part of it, that's for sure.
And how does that relate to healthcare reform, Rich?
Well, it's an excellent question. With healthcare reform, there is a push to have a more informed consumer and have the consumer make more choice. The problem you have is it's a very complex subject. Markets work well when you have kind of an equality of a knowledge base. So if I go buy a pair of shoes, I know what I'm looking for in a pair of shoes. do I really know what I'm looking for in a heart transplant other than the fact that it's successful? How do I shop for that? And a lot of the care you cannot shop for. So I just don't see that you can get to that kind of a solution. I think you're always going to have the physician involved with the patient to be able to make those kinds of decisions on an individual basis. What concerns me in healthcare reform is the move toward statistical determinations of a decision, where you've got the clinical effectiveness comparisons, what's more effective statistically, but it tends to leave out the individual decision of a particular patient with a particular set of history that may be the exception to the statistic. And that's something that everybody needs to watch.
And that's also the art of medicine as well.
You have to leave the art of medicine in. And there's some things that are working out there in the area of prevention that are also very concerning of what will be paid for. Well, it's statistically based. But what if you're the, kind of the outside the statistics? There was the big fight about breast screening. They wanted to up the age, but there's a significant number of women who would find it very beneficial to have mammography at a younger age. How do you deal with that? Doesn't fit statistics. Fits judgment, the woman, how she feels about what's going on. All those issues are not in there and need to be in there.
You talk about how complex and complicated it is. And in election years and in all the things we hear on TV, there are so many catchphrases and sound bites within 30 seconds. And a lot of times we had heard, well, it's free in England and it's free in Canada. It's maybe free at the point of delivery, but people are paying for it in taxes.
There's no such thing as free. The French system, not free, 21% tax rate to pay for your system. Really interesting and very good system. England, not free. Somebody has to pay for it. And if you look at what's taking place in England, there's some major, major problems with access, denial of care to the elderly, infection rates that are extremely high in certain hospitals. So there is a cost when you centralize and take control over a system. So no.
And they're moving to privatization, aren't they? They're moving closer to us.
They are, and I think the one thing that is somewhat ironic about the whole debate is part of the legislation requires for more individuals to actually go onto the Medicaid program, which is administered by the states. I think every state in the union is actually trying to get out of the Medicaid business because of the costs associated with it. When it was originally established, it was very low. In Florida, just in the last 2 years, you've seen it go from $6 billion to $20 billion. That's a cost. That's a cost to the taxpayers. But I do think that one thing, whether it's Medicaid reform or the most recent changes in Washington, the one thing that does seem to be a driving force, and was even before the discussion, is really being with that patient all the way through the process, having the follow-up, having really more of a long-term plan as opposed to just providing the procedure, which I think most hospitals and organizations have been moving in that direction anyways.
Well, it's interesting because as we look at what you've just said, Andy, there's a new standard that Medicare passed last year called Present on Admission standards. And that required that if there's a secondary condition that develops in the hospital, Medicare is not going to pay for it. What are the implications of that for hospital executives such as yourself?
Well, I think it actually goes back even before the most recent changes, back to 2005, I think was when this initially started to be discussed. One of the things that we have tried to do is really a patient-first model where you are working with that individual every step of the way, and then upon discharge, we actually have a home health model where we will actually set up a video conferencing ability in your home so that we can monitor your reaction to your time at our organization. And I think that's kind of the future with a lot of organizations, is really doing that follow-up so you don't have that individual actually being readmitted into the organization.
You folks have a similar philosophy, but let's take a look at the implications of this rule a little bit further. There's another part of this statute that suggests that if a person comes into a hospital and develops a secondary condition in the hospital, such as pneumonia, it won't be paid for. And if the person is discharged from the hospital and acquires a secondary condition within 30 days of discharge, that won't be paid for either. What are the implications for Florida Hospital?
Well, there's a couple of things. One, you go back to your present on admission. If something is present on admission, obviously you can incorporate that in the treatment. You get into two issues there. One is how diligent are you in identifying an issue as being present on admission, so you're going to step up some of your testing.
More costs.
Yeah, to make sure it's present on admission. But if there's something that develops in the hospital, you'll get your DRG payment, but if there's an added length of stay or whatever, no, you won't get paid for that. So there are some costs that's going to be absorbed. The other issue that you've addressed is the readmission issue. Readmissions on the Medicare population represent about 19%, right? 19% of all admissions are readmissions. And the new rule, the healthcare reform, has a penalty, not just a payback, but a penalty if you're statistically above the norm on readmissions for certain categories. So the hospitals are having to assume greater and greater responsibility for the care of that patient post-discharge. And there's a rational piece of that, so that we do good patient education, we do the home care. But interestingly, one of the biggest problems is getting the patient in to see a physician during the first 15 days post-discharge. I mean, we can do a lot by picking up the phone and calling the physician, but if the physician doesn't give you an appointment, there's a high probability that person's coming back within 15 days. And interestingly enough, we're finding, at least preliminarily, that if we take a much more aggressive stance with the home care, we're finding a slight increase in readmissions because we're wanting to opt for the safety of the patient versus avoiding a readmission. That'll get stabilized. But the other piece to that, largest source of readmissions, nursing homes, which is unaddressed in the Healthcare Reform Act.
And we'll finish this discussion in a moment. Again, we're talking about healthcare reform with Florida Hospital's Rich Morrison and Orlando Health's Andy Gardner. We're going to take a quick break, so stay with us. Thanks for joining us again. We're talking about healthcare reform with Florida Hospital's Rich Morrison and Orlando Health's Andy Gardner.
You know, there's a Harvard healthcare expert by the name of Clayton Christensen who's been talking about what needs to be done in order to make healthcare more readily accessible to Americans. And one of the things he suggested, Rich and Andy, is that primary care should be provided by physician assistants and nurse practitioners. I'd like to get your opinion, both of you, on that subject.
Well, if he's talking exclusively, then I'd have to say he's not necessarily being in a real world here, because you've got primary care physicians who are extremely well trained as diagnosticians, and I think you may lose something within that transaction as opposed to the training of nurse practitioners and physicians assistants. Now, there is, I think, an expanded role for nurse practitioners and physicians assistants because we've got a huge problem with access to primary care. And as you bring more people into the roles of being insured or in Medicaid, one of the fundamental problems that has not been addressed is who's going to see these folks? Right now, the default is going to be Mr. Gardner's emergency room and my emergency room and the emergency room physicians, because there's just not enough primary care out there. But to propose that we toss the primary care physician out and replace them with a different set of professionals, I don't think so. It can be expanded, and I think you have to reconfigure the role of the primary care physician so you get highest and best use of their training, skill, and experience, and use the other professionals in an expanded capacity, but let's not toss out primary care.
Thank you.
You can actually see that in our pediatrician's office. You can schedule an appointment with the pediatricians if you really feel that there's a problem, or they have in and out quick clinics with physicians assistants.
But you keep that oversight. There is still that primary care provider that is ultimately responsible for the decision. Each state deals with this argument, scope of practice argument, all the time. I would agree with Rich that one of the things that does have to be addressed is even just with the expansion of Medicaid in Florida, you're going to have about 1.5 million more people into the system looking for access. So there are some questions as exactly how do you address that, not to mention by 2020 the number of individuals that will be knocking on doors saying, you know, I want access now because of the health care plan that just passed.
Former director of the Congressional Budget Office on 60 Minutes recently said that without health care reform, in some form, some very aggressive form, we will bankrupt America's economy. He said that this is the one part of our economy that quite literally can bring us to our knees. What's your take on that?
Well, I think, you know, there's always so much focus on the cost of health care. And I think when we look at it, we look at really the quality of the health care that's being provided. I have 3 small children. If one of them has a problem, I fully intend to do whatever is necessary to make sure that my child is okay. And I think most people think the same way. What ultimately could potentially have an impact, I think, on the cost of health care is not containment or lowering what you have access to, but really coming up with that quality and that continuum of care from the beginning of the diagnosis or that primary care provider all the way to the end through a home health model. It's something that we feel very strongly about, but you know, even the most recent healthcare reform, there is numbers that are showing that healthcare costs will continue to rise under the existing, just based on the mandates of the individuals now that will have access. So I think it really depends on how you want to look at what we actually provide to a community.
And Rich, my good friend, you and I have debated healthcare reform very recently. Always have a good time when I have that opportunity with you. But I know you have some very strong opinions about the immediate and long-term impact of what we have on the table as healthcare reform.
Yeah, I'm not so sure that we've got healthcare reform. I really am not. You've got some insurance reform. You've got some things that are really not going to drive down the cost. And as a matter of fact, if you look at the Congressional Research Office, they project an increase in cost, not a decrease in cost. We've got a thing called baby boomers. There's a fundamental flaw in Medicare that, you know, benefits kick in at 65. Well, there's, you know, a false premise of what happens at 65. It used to be good because everybody, you know, your audience will get freaked out here, but it was great projection because everybody died when 65 was determined as a retirement age. Well, that's not the case anymore. So you've got this long-term obligation, but it's unfunded. Do you have to drive down the cost? Absolutely. How you get there becomes the fundamental issue. Do you go to rationing? Do you go to much more of a preventative approach with people, young people like me, who are 61, so that we're not consuming some heavy-duty stuff? Do we deal with, in a rational way, not death panels, but really coming to grips with it as a nation, the issues of end of life? Do we demand everything be done even though there's no hope and possibility a person can survive? So yeah, healthcare costs are going to plague us for a long, long time, but it's not going to take politics. It's going to take a look by the population themselves and say, what is it that we want? What do we want to pay for? And if I may add, Cutler, who was one of the advisors and an economist from Harvard, said the spending of the amount of our gross domestic product on healthcare was not really the big issue, because people live longer, they spend more. So there is an economic value to extending life. His concern was the tremendous variability that exists on expenditures across the country and the over-demand of the system because we're extremely consumer-oriented. So we have to look at that nuance as we look at healthcare reform.
Well, let's take a look at the 3 wants of all Americans, gentlemen. 1, when we want health care, we want it immediately. When we need health care, we want the best health care we can have. And most people who are experts in the field say, and when we get that health care, we don't want to pay for it. Now, Rich, you made a comment just a few moments ago about Germany, England, France, where they all pay taxes, very high taxes to support their system. Has the time come when we have to initiate a fair tax in terms of health care reform for all Americans?
I'm not sure what you mean by a fair tax. I do not see this country saying, gee, take 15% of my income and put it to health care. I think that we still want to make those decisions about what we want to pay for. The dichotomy, of course, is with Medicare, but Medicare is coming out of your paycheck. You're paying for it. there's a wrong calculation as it relates to the age and how we're funding it. But in terms of universal health care, I think as a body politic, we are much more comfortable paying for it ourselves, at least in our younger years. I don't think we've got the will for that.
We haven't also touched on the litigious society we live in and the cost that adds as well.
And just to add to your point, I think that the one thing that does get lost in this whole debate is that we really do have the greatest health system in the world. If you look at the hospitals that are providing care, whether you're in Miami, you have individuals flying in from South America for procedures. In many of the countries that you mentioned, people are actually coming here for those procedures because it's better quality, it's better access, and that obviously is what makes this whole debate about healthcare is where exactly is the problem. You know, if the organizations are focusing on quality, which I believe they are, and patient first, then a lot of these issues get resolved. But to your point, as you were about to say, the one thing missed in the whole discussion is the legal reform aspects of preventative medicine that sometimes is done because of the fear of any legal action that may happen.
But coming back to costs, and it's interesting, we've got, I think, absolutely the greatest healthcare system going. We have a huge lifestyle problem in this country. People still smoke too much, big expense. We've got an obesity problem to beat the band. We've got a substance abuse problem. So we've got all of these social issues that tend to drive into healthcare costs, but are not necessarily reflective of the expense of healthcare, of operating healthcare, or the quality thereof. We've got a big problem on the other side that we still are not willing to come to grips with.
And you are starting to see health insurance companies take much more of an approach of lowering your cost for health insurance based on your lifestyle, smoking and others, and exercise. And those are all aspects that ultimately will help the system to overcome many of the changes that are coming down the pipe.
We've had so much to talk about. We've been talking with Andy Gardner, Vice President of Community and Government Relations for Orlando Health, and Rich Morrison, Corporate Vice President of Government Affairs for Adventist Health Systems.
And that's all the time we have for today. I'm Aaron Lieberman from UCF's College of Health and Public Affairs, sitting in for Ed Highland.
And I'm Charna Wasey. Thank you for joining us, and we'll see you again next time on For Your Health.
This program was made possible by a grant from the UCF College of Health and Public Affairs, which promotes excellence in undergraduate and graduate education, research, and community service in health-related professions and public affairs.